This is imaging of rib stress fracture. I'm Pat Battaglia from Logan University. I thought I'd start this lecture with a case from the literature. Here's a young weightlifter with left upper extremity pain and swelling and distension and prominence of the collateral vessels of the upper extremity. Like most things, unfortunately, this has an eponym associated with it called Urschel's sign, which is distension and prominence of the collaterals of the upper extremity vessels. Here's the patient's radiograph, and take a minute and see what you see. Recall this patient had left upper extremity pain and swelling, and if you look closely, the angle of the first rib is expanded, in this case secondary to fracture with callus formation. Here's the patient's CT image. Here's some of the vascular anatomy draping by this area of first rib callus with subsequent compression of the vascular anatomy. So in this case, this is a rib stress fracture secondary to weightlifting resulting in vascular thoracic outlet syndrome, otherwise known as Paget-Schroeder syndrome, also with Urschel's sign on clinical exam. I thought this would be an interesting way to start our discussion of rib stress fracture. I also wanted to take just a few minutes to review some of the salient features of bone anatomy, in particular periosteal anatomy and periosteal disease or patterns of periostitis on imaging. In the other lectures for this series, I've discussed soft tissue anatomy of the TFCC, the labrum, and the intervertebral disc. This is our only time discussing bone anatomy. Oftentimes, we're going to investigate rib stress fractures with radiography first, and then ancillary imaging such as CT, MR, or ultrasound second. So it's really important we appreciate what we are and are not looking at in the interpretation of a suspected rib stress fracture. In particular, we want to make sure we're not overcalling a rib fracture when we should be considering other more sinister patterns of bone disease. Understanding patterns of periosteal reaction can help us not fall into this trap. So here's our typical bone, long bone, for example, with inner cancellous and outer cortical bone. And on the outside of this bone is a strip of connective tissue called the periosteum, and on the inside is a strip of tissue called the endosteum. Periosteum covers all bone surfaces except intra-articular anatomy. It would reflect and form part of the joint capsule. For our purposes, we're going to study the periosteum a little bit more. So if we zoom in on this bone, we see the periosteum has two discrete layers. One is an outer fibrous layer, that's cell poor, and the inner layer, rather, is a cell-rich osteogenic layer. There's a lot of undifferentiated osteoid cells in here and osteoblasts within this layer. Connecting these layers to the underlying bone are Sharpey's fibers, collagen fibers. Now these fibers have weak connection in pediatrics. This explains a number of the unique pathologies we see in our pediatric athletes, things like periosteal sleeve avulsions, things like periosteal hematomas as well. In addition, the prominence of the periosteum in the pediatric athlete, or any pediatric, and the prominence of the inner cell-rich layer is why, with rare exception, two bones in close proximity or even in the same room together will heal nicely in a pediatric patient without the need for surgical fixation because of the bone forming potential of the periosteum. We lose that over time because we lose the density of our periosteum. The periosteum has a rich neurovascular supply, and this is where most of the nociceptive potential of bone lies, is within the periosteum, not within the cortical or endosteal bone. The gross anatomy is as follows. You can see the reflected periosteum here from the underlying cortical bone, and on microscopy, appreciate the outer fibrous layer with mostly collagen tissue, which is cell poor, and then the inner cambium layer, which is cell-rich with osteogenic potential. Comparing and contrasting the pediatric to the adult periosteum, note the thickness of both the outer and the inner layer of periosteum in the pediatric patient relative to the adult patient. We can see periosteum quite nicely on our ultrasound exam. Here's a pediatric fibula, distal fibula. This is the growth plate here This is the lateral malleolus and the distal fibular shaft, and all of this anatomy here is periosteal anatomy as it drapes over. Again, rich osteogenic potential. This is why kids can heal quite nicely. This is also why kids get aggressive periosteal reactions when there's underlying bone pathology, because of the rich osteogenic potential here. Compare that to an adult patient. Here's the distal fibula in an adult patient, more proximal with the peroneal group on top, and we don't even appreciate that periosteum is present here, but we do not really appreciate it on this bone. Whereas in the pediatric patient, we see this nice layer of periosteum. Now, this was just a backstory to explain this, which are patterns of periosteal reaction. We're going to be dealing with stress reaction in the rib in a minute, of which oftentimes periostitis or a periosteal reaction is the only clue that the patient has a stress reaction in bone, whether it's rib or metatarsal, bone, what have you. Now, these patterns of periosteal reaction range from solid to interrupted, and this range spans the disease aggressiveness of a periosteal reaction. Solid periosteal reactions are benign. These are typically stress fracture, healed fracture, perhaps very, very benign tumors like an osteoid osteoma. Single-layered stress fracture, or single-layered periosteal reactions rather, are oftentimes benign, but they may signify more sinister underlying pathology. So if you appreciate a single-layered periosteal reaction in your patient's bone, and you are not 100% convinced clinically it's coming from a stress fracture, you'll want to pursue that further. The remaining layers require diligent multimodal imaging and probably multidisciplinary investigation. Multiple layer, known as lamellar or onion skin, spiculated, otherwise known as sunburst, and interrupted, otherwise known as Codman triangle. The pathology of a solid periosteal reaction is as follows. This is usually secondary to something abnormal housed exclusively within the bone. So here, for example, would be a stress fracture within the bone with subsequent release of inflammatory cells, these red dots here. These inflammatory cells stimulate this inner cambium layer to produce more bone, to produce more periosteum. So the disease process is staying within the bone. There's an extravasation of some inflammatory material that's causing bone stimulation, which is what we see in our patients with stress fracture, like a stress fracture here of the second metatarsal, or of a very benign bone tumor such as an osteoid osteoma. The tumor itself is contained within the bone, but its inflammatory process is inciting bone production from the inner layer of the periosteum. In a single layer, the same phenomena occurs, whereby the disease process is staying within the bone. Again, a stress fracture stays within the bone, but surrounding inflammation creeps out, stimulates the inner periosteal layer to produce new bone. Here's a pediatric athlete with stress fracture of the posterior aspect of the fibula. Other indolent disease processes, such as a slow-moving infection, will do the same thing. The infectious process here stays within the bone, but inflammatory cells sort of leak out and cause stimulation in a relatively slow-moving fashion of one layer of new bone, that periosteal reaction. Slow-moving malignancy can do the same thing. However, here's a patient with leukemia, permeative pattern of bone destruction, right here on the radiograph, with a linear, single-layered periosteal reaction, nicely shown on the axial CT image as well. The take-home here is that a single-layered reaction can be malignant, benign, or stress and/or infectious. So if you're not 100% convinced clinically, if your patient has a single-layered reaction, say by their rib, you need to pursue that further with more imaging. Now, the remaining patterns I'm just going to gloss over, but principally they involve two things. Number one, they involve the tumoral process, almost always, less likely an infectious process, but a tumoral process physically sticking out of the bone, displacing the periosteum, and stimulating new periosteal reaction. If it moves somewhat slowly, you get this layered appearance that you see here and here, this layered or lamellar or onion skin. But as it moves faster and faster, such as in an aggressive bone tumor like osteosarcoma, the periosteum is displaced perpendicularly and it starts oriented in an atypical fashion, like in the sunburst reaction here. Sometimes the tumoral process moves so quick it physically displaces all of the periosteum, forming this triangular pattern known as the Codman triangle. So this is not a lecture on bone tumors, but I think it's real important if we're talking about bone pathology, like bone stress injury. We always keep tumor and infection in our differential and contexted appropriately. And let's go into imaging of rib stress fractures. So rib stress fracture investigation should probably start with radiographs if ultrasound is not available, because radiography is widely available, it's low cost, and it's specific. However, the sensitivity is terrible. In the early stages of a rib stress fracture, radiography is going to have as low as 10% sensitivity and may go as high as 70% later in the game. CT is effective. CT is very effective for stress injury throughout the skeleton. Think of PARS stress injury, for example, or spondylolysis. CT is the best test we have to detect those, but CT uses ionizing radiation, which would be helpful to avoid, in particular in our athletes. But CT is effective. There's just a radiation burden, and this is radiosensitive tissue with the thorax, especially in the young patients, so we want to be cautious of that. Bone scan similarly has high sensitivity, it lacks specificity, and it's radiating, so we try not to use bone scan much, if at all, when imaging musculoskeletal pathology like a stress fracture. MRI will have the highest combined sensitivity and specificity, but it's expensive and it may not be widely available, and you get a lot of anatomy on the MRI, so you do open yourself up to a lot of false positives. Ultrasound's emerging. It's got pretty good sensitivity and specificity, around 70 to 80%. It's targeted. It's usually widely available, and it's low cost, and it does not use ionizing radiation. So if ultrasound is available, I'd consider ultrasound first for my rib stress fracture questions. If I can't make the diagnosis there, I progress on to further imaging. All right, just to summarize what the patterns of stress fracture look like on these various imaging modalities. Here's a coned-in view of the thorax showing nicely stress fracture of the first rib, bony expansion, fracture line, and callus formation. It's important to note that for first rib stress fractures, these are common in throwing athletes, and cervical radiographs will be your best diagnostic test. You don't have to get a whole chest radiograph, and shoulder radiographs are not helpful. Cervical radiographs will be your best diagnostic test. Oftentimes, these patients will present with upper back or shoulder pain. However, cervical radiographs will be the test you want to obtain. They almost always can show the fracture if it's detected by radiography. CT will be a fancy looking x-ray. You'll see better indication or demarcation of the fracture line with clearly demarcated callus. You will not appreciate the adjacent edema in the soft tissues or the bone. However, I think the diagnosis would be pretty clear off of a CT. It's very sensitive compared to radiography. In ultrasound, you'll see offset of the cortex. So on the top panel here, these are normal images. On the bottom are stress fracture images. So notice how normal bone has a linear, hyperechoic or bright appearance with shadowing and something called the reverberation artifact, all this noise underneath. So this is where the rib is. Everything beneath it is nonsense. It's artifact. So this is rib, linear, and this is rib fracture. Linear here, and then a break, an offset in that cortical alignment, like so. And sometimes there's even displacement of the overlying intercostal muscle. Comparing ultrasound to MRI, again, in the ultrasound, it's kind of like a microscope with high spatial resolution compared to most of our imaging modalities. So we can see nicely this cortical offset that we might not appreciate in the region of rib fracture on MRI. What MRI does show us that ultrasound does not is all this bright stuff. So all this bright stuff here is edema within the bone. Now we cannot see inside the bone marrow on ultrasound. It's a blind spot, so it's important to appreciate that. In particular, if we have any concern that this is not a stress fracture and it's malignant or infectious in origin, then MR would be warranted to evaluate the bone marrow. But if you have high clinical concern it's a stress fracture, this is diagnostic. Cortical offset, displacement of the overlying soft tissues. On MRI, you'll see a fracture line. Usually it's low signal, sometimes it's high signal, surrounding hematoma on both surfaces, this bright stuff here, and edema within the bone. Some of this is artifact, not all of this is edema in the patient's bone. Nice example again of a stress fracture. Fracture line, offset in the cortex, a little bit of callus formation, and then edema surrounding the region of fracture. Differentials to consider, one very scary, the other not so scary, but common and tough to diagnose at imaging. So chest wall sarcoma and side strain injury are the two main differentials to consider in the context of rib stress fracture. Here's a case from Radiopedia showing us chest wall sarcoma. Credit to this contributor. PA radiograph of the chest. If we look closely at the angle of the rib here, permanent pattern of bone destruction with a multiple layered periosteal reaction. Go down to the CT exam. Here's a normal rib in cross section, the outer bright cortex and the inner sort of gray trabecular bone. And then here is the region of sarcoma. Note the pattern of bone destruction and note the extensive soft tissue mass. This is not hematoma like we would see in a fracture, rather these are tumor cells and soft tissue tumor mass. And then note the pattern of periostitis, not typical for callus that we saw in rib fracture. So chest wall sarcoma needs to be considered in the right clinical context, especially in our young athletes with persistent thorax pain. Don't just assume it's rib stress fracture. In addition to chest wall sarcoma, a more common and thankfully more benign condition that may mimic rib stress fracture is myotendinous junction injury of the internal oblique muscle, otherwise known as a side strain injury. So here's the internal oblique muscle as it